Good afternoon, dear students. Today, we will discuss a very important topic concerning general management of patients with pneumonia, pluritis, and fever of unknown origin, FUO. Frankly speaking, this lecture can be divided into three separate lectures: pneumonia, pluritis, and fever unknown origin. That's why, due to the limit of time, I give you only key. Using this key, you can open our understanding according management, according differential diagnosis and treatment of these disorders. Let's start with fever of unknown origin, because this problem we didn't discuss during previous courses. First, definition of fever. Fever is an elevation of body temperature that exceeds the normal daily variation and occurs in conjunction with the increase in the hypothalamic set point from 37 degrees of Celsius to 39 degrees of Celsius. A fever more greater than 41.5 degrees Celsius or more than 106.7 degrees by Fahrenheit is called hyperpyrexia. So I would like to note you in healthy adults, the range of normal healthy temperature is, for oral temperature, is 36.8 to 37.3 degrees Celsius. You should measure this temperature no less than 3 minutes. For rectal temperature is about 37.3 to 37.7 degrees Celsius, and for axillary temperature, armpit, it's from 35.5 to 37 degrees Celsius. You should measure this temperature at least 10 minutes. And according Harrison principles of internal medicine, defines a fever as a morning oral temperature more than 37.2 degrees Celsius, or an afternoon oral temperature more than 37.7 degrees Celsius, while the normal daily temperature variation is typically half degree of Celsius. Hyperthermia, heat stroke. It's characterized by an uncontrolled increase in body temperature, then exceeds the body ability to lose heat. The setting of the hypothalamic thermoregulatory center is unchanged. In patients with heat stroke syndrome, and in those taking drugs that block sweating, the skin is hot but dry, whereas in fever the skin can be cold as a consequence of vasoconstriction. By the way, a patient with hyperpyretic fever due to significant vasoconstriction, you should pay attention to this condition, because, for example, if you check and measure, perform pulse oximetry, you it will be false results of this measure due to vasoconstriction. And first definition of fever of unknown origin, FUO, by Petersdorf. First, temperature greater than 38.3 degrees of Celsius or 101 by Fahrenheit on several occasions. Duration of fever greater than 3 weeks. Failure to reach diagnosis after 1 week in hospital. So there are 4 categories of FUO exist. First is so-called classic FUO. Definition: temperature more than 38.3 degrees of Celsius, by the way, in oral cavity. In axillary temperature, approximately more than 38 degrees of Celsius. Duration more than 3 weeks, and or evaluation of 3 visits or 3 days in hospital. That's why patient, for example, was admitted to hospital, but with fever, but during 3 days in patient condition, we couldn't make correct diagnosis and find origin of this fever. And the leading causes of this fever: first, malignancy, infection, non-infection inflammatory disease, and other. Nosocomial, temperature the same. Patient was hospitalized. Patient were hospitalized more than 24 hours. Fever not present during admission or before admission. Evaluation at least 3 days, and that's why no diagnosis. That's why we can write to in the main diagnosis FUO, fever of unknown origin. Leading causes of this nosocomial FUO: it's healthcare associated infection, postoperative complication, and drug fever. Neutropenic immune deficiency fever, patient with the same fever plus criterion of neutropenic fever is absolute neutrophil count equal or less than 500 cells per milliliter. And evaluation the same as the nosocomial, at least 3 days. Majority due to infection, bacterial, fungal, and viral. And HIV associated FUO fever the same. Duration more than 3 weeks in outpatient condition and 3 days for inpatient. And HIV infection confirmed. And primary infection HIV, mycobacteria, typical or atypical, cytomegaloviruses, lymphoma, toxoplasma, cryptococcus, immune reconstitution inflammatory syndrome. The leading causes of this HIV-associated FUO. In this slide, you can see that in main country, the main causative factor of FUO is infection. Approximately 50% of in cases of FUO in India, 33 in the US, and 27 in Europe. And second place, it's neoplasm. 22% in India, 25 US, and 13 in Europe. And then it's miscellaneous. And for example, in India, 9%, it's fourth place, obtained connective tissue disease. And in each country, in India, US, Europe, and total, and from 5% to in India to 23% in Europe remains for FUO undiagnosed. That's why under the very carefully complete diagnostic, we can't to make final diagnosis, we can't find origin of this fever. You can see that in this slide, that's classic FUO that during last 4 decades, you can see the gradual diminution of FUO infection due to improved technique of lab investigation for infection, and diminish the prevalence of malignancy, increase inflammatory disease, and other, and unfortunately increase no diagnostic cases. Few words about classical FUO. First, it's unrecognized abscess, abdominal perinephric abscess, endocarditis due to Hasek organism and other microorganism which difficult to culture, including Bartonella, Aspergillus, Coxella, Brucella, and others. And tuberculosis, histoplasmosis, and osteomyelitis. By the way, it's very interesting. In the last case, the diagnostic tuberculosis after 3 months of FUO, and only when tuberculosis started progression, and we detect the changes in the lung due to high resolution CT scan, and we use PCR technique of detection of MBT in sputum, and we confirm diagnosis of tuberculosis. Also, let's know for you that quantiferon gold test, it's very important for diagnosis of tuberculosis infection. Now, according to common connective tissue causes, it's inflammatory process, adult still disease, which accompanied by fever, rash, and arthritis, rheumatoid arthritis, systemic lupus erythematosus, temporal arthritis in persons more than 50 years of old with headache, symptoms of polymyalgia rheumatica, and higher ACR, higher C-reactive protein. Common malignancy associated with FUO: lymphoma, leukemia, tumor metastatic to liver, renal cells, carcinoma. And by several cases of FUO in my practice, the cases with patient with lymphoma, and monitoring for this patient with FUO helped me to, for example, retest of high resolution CT scan helped me to detect enlarged lymph nodes root of in the region of lung roots, and we perform biopsy of this lymphoma and lymph nodes and confirm the diagnosis of lymphoma. And several cases FUO which associated with tumor of the lung. It may be very small. It was a very small diameter of this tumor, and with a company significant of increase of body temperature. But when we find this approximately 1 centimeter diameter of this tumor, we confirm the origin of FUO. By the way, the main mistakes for general practitioner when we meet FUO, a lot of physicians give patient corticosteroids, and in many cases, including lymphoma, metastasis, carcinoma, and other fever normalize and reduce. But sometimes it's lead to misdiagnostic and delayed our diagnostic way for confirmation of real origin, real causative factor of FUO. This is why my advice for you, don't prescribe corticosteroids if you don't know about origin of disease, because you can lead to harm of patient and delayed diagnostic, misdiagnostic. Okay. Miscellaneous causes of FUO: factitious fever and for example, self-induced drug fever. In drug fever, often typically not only for classical, but for hospital FUO. For example, prescription of antibiotics, antihistamines, non-steroid anti-inflammatory drugs sometimes lead to drug fever, and stop of consumption of these drugs lead to a resolution of the fever. Familial fever syndrome, familial Mediterranean fever, tumor necrosis factor receptor associated periodic syndrome, hyper IgD syndrome, hemophagocytic syndrome, inflammatory bowel disease, often undiagnosed inflammatory bowel disease lead to fever of unknown origin, pheochromocytoma, pulmonary embolism, thrombotic thrombocytopenic purpura, and thyroiditis. The main causes of miscellaneous causes of FUO. So, nosocomial FUO include patients who have a fever start after at least 24 hours after to admission to hospital, after hospitalization. In etiology, the main causative factor also drug fever, nosocomial infection, post-operative complication, and central fever in patients who have got a stroke after hospitalization. Immune deficiency FUO in patients with significantly impaired immune response often do not have traditional signs of inflammation. This makes detection of infection more difficult. Neutropenic, we told, equal or less than 500 polymorphonuclear leukocytes in 1 milliliter of the blood. It leads to decrease of mucosal defense and innate immunity. Febrile neutropenic patients receive empiric courses of broad-spectrum antibiotic and often antifungal agent. In this slide, you can see, for example, in the case of neutropenic FUO, approximately 40% patient with fungal infection. The 25 are unidentified, including drug fever, toxic effect of chemotherapy, and other. And third place, bacterial infection, cryptid foci, and resistant organism. And now achievement in treatment of HIV patient lead to significant diminish of the prevalence of HIV-related FUO in general and general characteristic of FUO. In a patient with HIV-related FUO, and common cause, it's firstly mycobacterial disease, pneumocystic, for example, pneumocystic Girovechi pneumonia, cytomegaloviruses, histoplasmosis, lymphoma, and drug fever. Evaluation of FUO. First, you should obviously verify fever and establish pattern. In previous course, you should know the pattern of fever. It's, for example, remittance, intermittence, and other. We have, due to limit time, I can't I can't give you more details according to this pattern, and I sent you for a course of propedeutic of internal disease. Firstly, you should pay attention to localizing symptoms and syndromes. You should ask patients about workplace, pets, recent travels, history of connective tissue disease, family history of cancer, immunosuppression, medication, drug use, familiar fever syndromes. You should see the pattern of the fever continue, fever remittance, intermittence, underlying fever, and relapsing fever. When during physical examination, inspection, you can check temporal artery in elderly patient, sinus tenderness. In this portrait of Francesco Zamberti, Piero di Castima, you can see the presence of this temporal artery enlargement, and in such patient can have symptoms of rheumatic polymyalgia, fever, and headache. And during physical examination, you should listen for heart and listen murmur, and look for signs of endocarditis at the skin. Firstly, it's oscillatory nodes, general lesion, conjunctival hemorrhage. It's leukemia signs. Looking signs. In this leukemia signs. It's general signs, hemorrhage of the palmar, lymphadenopathy and thyromegaly. It's very important things, and lymphoproliferative disorders often accompanied by FUO and undiagnostic. For example, lymphogranulomatosis. It's often it's a causative factor of FUO. Also in this portrait, Change and his wife, you can see to the lateral parts of the neck, enlargement lymph nodes, chains of lymph nodes, and with pale due to lymphogranulomatosis, and pale face, maybe due to anemia in wife of Changes. Peripheral abscess in a case of neutropenia, typically as a causative factor of FUO. Splenomegaly and hepatomegaly, deep vein thrombosis. Skin, mucous membrane, teeth, you also, it should be complete investigation. Evaluation of FUO, including common clinical analysis, including a common blood count, biochemical liver function. By the way, I met with such clinical cases, patient with FUO. After several biochemical tests, we detect a significant increase of liver enzymes. That's why patient used, due to maybe virus infection, previously used a lot of paracetamol, acetaminophen, and it's lead to damage of the liver. And this patient death due to acute liver failure, but biochemical investigation help you to detect liver damage and start of therapy, correct therapy, but unfortunately we couldn't help this patient. That's why obviously you should check liver function test, urine analysis, blood culture, HIV antibodies, chest X-ray, high resolution CT scan, ultrasound examination. Well, very important thing is C-reactive protein as a acute phase protein. It's increase of CRP. It's confirming about increased systemic inflammation. By the way, normal range up to 5 milligram per liter. From 5 to 10, it's so-called low-grade fever. The low-grade systemic inflammation. low-grade systemic inflammation. When we detect CRP from 5 to 10 milligram per liter and more, it's significant systemic inflammation. It's, for example, patient with now it's coronavirus disease have got sometimes 200, 300 CRP and more. Procalcitonin, it's very important lab parameter which help you to detect and suspect bacterial etiology of FUO, and we will say more concrete about this parameter when we will discuss differential diagnostic between virals and bacterial pneumonia. Selective serological serological investigation for infection and using of ELISA test and PCR test. Also for detection of FUO, we use bone marrow biopsy, incisional lymph node biopsy. I would like to, if we are not talking about peripheral lymph nodes, we use only incisional. We removed whole lymph nodes and make slides and for detection, for example, lymphoma, lymphogramatosis, and other. In case of enlarged, for example, lymph nodes in the lung, for example, in the root of lung, we can use transbronchial needle biopsy of lymph nodes. It's the methods which help you to detect and confirm the diagnosis of sarcoidosis when we detect the specific granulomes. Granulomes typically non-caseous without caseous central caseous necrosis. In case of central caseous, the presence of central caseous necrosis, you should confirm about TB infection, tuberculosis. In this slide, you can see the Doppler ultrasound investigation of vessels and the presence of thrombus and a blood flow around the thrombus. That's why FUO, due to, for example, deep vein thrombosis. And positron emission tomography. It's a very important topic in the method, a very important method for detection of some kinds of tumor. In this slide, you can see the lung cancer. For example, in the cancer in gallbladder. And so in this slide, you can see the pattern for evaluation of FUO. In initial evaluation, fever persists more than 3 weeks. If patient used drugs, try to stop drugs. If fever disappear, it's you can explain FUO, drug FUO. That's why very important thing is this stop of all non-essential medication. If you can, you should. Several cases you should not start. For example, in the case of, for example, neutropenic FUO, you should not stop antibiotics and antifungal drugs, for example. and other. If you made this stop of consumption of medication, if a patient persists, you should perform abdominal CT scan and positron emission tomography and other nuclear scanning. Then you should exclude infective endocarditis. You should know your Duke criteria, which including the presence of culture in the blood and the lesion of heart valve, ultrasound investigation, and it's a major on minor criteria, Duke criteria for infective endocarditis. And then you should use leg Doppler imaging, confirm of the deep vein thrombosis, and prescribe, for example, specific treatment. And in the patient age more than 50, you detect enlarged of temporal artery and with pain due to palpation and spontaneously, you should make temporal artery biopsy. So if after all investigation, you can't to make a final diagnosis, you should follow up for this patient, and it's very important because due to monitoring in outpatient sometimes condition during maybe several months, sometimes the origin of this FUO happen. And other things you can't, you suspect, for example, the damage of liver, for example, liver biopsy, laparoscopy, also can use. Well, the management of FUO, this called therapy until the cause of infarct is found exception, neutropenic fever, corticosteroids suspected in temporal arthritis, and unstable hospitalized patient. It's exception for stop of medication. Outcome of FUO. Mortality rates from 20 to 35 for classical FUO. Higher mortality if malignancy is identified. Lower mortality is infection is identified. If no occasion identified, this from 50 to 100% in this case, series have a spontaneous recovery. That is good news. If no identified from 50 to 100% in this case, as spontaneous recovery of patient. So summary is a definition of classical fever more than 101 by Fahrenheit for 3 weeks. No diagnostic or after 3 days in hospital or 3 outpatient visits. Fever present more than 3 weeks, 3 days patient hospitalized, no diagnosis, and 3 outpatient visits. Definition differ from patient with neutropenia, HIV, or suspected nosocomial onset. Causes of FUO are diverse, but can be categorized into infection, malignancy, connective tissue disease, and miscellaneous disease. That's why first you should think about infection or malignancy. Comprehensive history and physical examination are an important first step in FUO evaluation. Evaluation of FUO with lab tests and imaging should be directed toward the most likely causes based on the history and physical examination. The key to management of FUO is to withhold specific treatment, but must be noted as exceptions until the cause is found. It's very important things. That's pluritis. I would like to ask you, is it a main diagnosis? No, it's not main diagnosis, it's complication. Pluritis, note, it's complication from different condition, different disease. I would like to know that there are two layers of the pleura, first parental pleura and visceral pleura. The space between parental pleura and visceral pleura is called the pleural space. Normal pleural fluid, it's needed to diminish the friction of the lung during breathing. It's pleural fluid, it's frankly speaking, it's ultrafiltrate of plasma. Enters the pleural space primarily through the capillaries in the parental pleura and removed via the lymphatic in the parental pleura. Forms a thin layer in the pleural space. pH from 7.6, 7.64. Protein content less than 2%, from 1 to 2 grams per deciliter. And white blood cells less than 1,000 per milliliter. Lactate dehydrogenase level less than 50%, the lactase dehydrogenase level in plasma. In pleural fluid, glucose content similar to plasma. Pleural effusion happened due to enlargement of pleural fluid due to increased capillaries hydrostatic pressure, chronic heart failure, superior vena cava syndrome, reduced intravascular oncotic pressure, hypoalbumin, anemia, liver cirrhosis, nephrotic syndrome, increase oncotic pressure in pleural space. For example, in case of tumor, because malignancy cells it's very active growth of tumor cells, increase oncotic pressure in pleural space. Sometimes some kinds of pleural tumor affected pleural. For example, mesothelioma of the pleura, it's characterized by very rapidly formation of huge pleural effusion, often bilateral. Increased capillary permeability or vascular disruption, also in case of neoplastic disease, infection or inflammation, in case of pancreatitis. Decrease of lymphatic drainage. For example, I met with such cases in women with breast tumor after surgical operation, after radiochemotherapy, due to damage of lymphatic drainage, fluorosis of lymphatic drainage. Reduction in pressure in the pleural space, rapid lung, increased flow of fluid from the peritoneal cavity in case of liver cirrhosis, increased flow of fluid across the visceral pleural, pulmonary edema, disruption of interthoracic vessels and thoracic duct, and jatorogenic. And the clinical symptoms and signs, including dyspnea, is the most common symptom. It usually indicates large, more than 500 milliliter effusion. Chest pain if affected of parental pleural, because visceral pleural is painless. Dullness of or decreased resonance to percussion, a diminution of inaudible breath sound, a decreased tactile frequency. By the way, clinically you can rule out, for example, pneumonia from pluritis, because in both cases, pneumonia and pluritis, it's dullness or decreased resonance to percussion. But in case of pluritis, it's a decrease of tactile frequency. In case of pneumonia, due to consolidation of lung parenchyma, it's lead to increase of tactile frequency. Ergophony, you also use pleural friction, asymmetrical expansion of thoracic cage, mediastinal shift. Other findings that provide clue to cause of pleural effusion. Key symptoms I would like: shortness of breath, fluid filling the pleural space, make it hard for the lung to fully expand, causing the patient to take many breaths so as to get enough oxygen. In parental pleural is irritated, mild pain, or sharp stabbing. So-called pleuritic type of pain, exacerbate and increase due to breathing, during breathing. Some patients will have a dry cough. Sometimes you can find the pleural effusion only in during X-ray examination of CT scan or ultrasound. No symptoms. No symptoms. In what clinical cases? Mostly in the young person, it's mostly TB process. In case of elderly patient, mostly it's pleuritis associated with tumor. There's no symptoms at all. Sometimes since recent abdominal surgery, often accompanied by such type of pleuritis without any symptoms. In this slide, you can see the typically X-ray pattern of X-ray pattern. Now the pleural fluid to the left side, fluid itself can be seen at the bottom of the lung or lungs, hidden the normal lung structure. Heart failure is present. Ultrasound, the investigation confirmed, especially in case of limitation, localized pluritis. And also CT scan is very important method for detect of pleural effusion. But it's very interesting. New shadow in the total shadow in the left lung, and here the same. But you can see the shift of mediastinum opposite this shadow. It's in this case it's pluritis, and toward the shadows, you can see the shadows of the trachea, bronchi, shift to the left. It's in this case, it's pleural total ectomy of the left lung. Sometimes in case of collapse of the lung. That's why important things you should check the shift to mediastinum. So pleural effusion in general, it's indication for thoracentesis. Can be thoracentesis may be divided into two categories. First, it's diagnostic thoracentesis and therapeutic. Diagnostics detect underlying diagnosis, help you to detect underlying diagnosis. Therapeutics relieve shortness of breath. Sometimes you help you to treat for example, empyema of the pleural from removing the pus from the pleural cavity and inject of some kinds of drugs into the pleural cavity. We will say about it later. And when we obtain, but by the way, in general, pleural fluid should be confirmed by with X-ray or CT scan, ultrasound investigation. Then you should analyze indication or contraindication for pleural synthesis. We will say about it later. And then when we obtained sample for the pleural fluid, you can evaluate the type of pleural effusion. In case of reddish of pleural fluid, it's hemothorax. It's the presence of blood. In case of chest trauma, rupture of aortic aneurysm, hydrothorax, congestive heart failure, helothorax, lymph, it's neoplastic trauma, pneumothorax is the presence of air in the pleural cavity. In this case, you can see the fluid in the right part, right lung, right chest, and here air is a pleural pneumothorax. So color fluid, pale, It's transudate, some exudate, red, bloody, malignancy, embolism, TB, turbid, infected, infusion, pus, empyema, and white, milky, hyalothorax of cholesterol effusion. By the way, what the main indication for thoracentesis? If the pleural effusion more than 100 milliliter in the lateral position, it's indication for pleural effusion. But in all cases of practically in all cases of pleural effusion, it's indication for diagnostic thoracentesis, but one exception. If patient have got a chronic heart failure and patient have got a bilateral pleural effusion, cardiomegaly, and febrile, no chest pain, you can try to treat such patient with diuretics. If effusion persists more than 3 days despite diuretics, and patient have got a fever, pleurisity, pain, unilateral or asymmetrical pleural effusion in absence of cardiomegaly, atypical features present, it's indication for thoracentesis. By the way, now practically no absolute contraindication, but needle thoracentesis with needle diagnostic, it's help you to find origin of this pleural effusion. It's very important since. But I would like to say that now rule out exudate from transudate help you to so-called light criteria. Light is professor of medicine of Tennessee University of US. He have more than 300 articles for investigation in the field of pleural effusion. He proposed some criteria which now called light criteria. Please note about this criteria. Pleural effusion that meet one or more of 3 light criteria are classified as exudate. So ratio of pleural fluid protein level to serum protein level more than half, 0.5. That's why it means if less, that you should make conclusion about transudate, because prevalence of serum protein under the pleural fluid protein. Ratio of pleural, second criteria, ratio of pleural fluid lactase dehydrogenase level to serum lactase dehydrogenase level more than 0.6. So lactate dehydrogenase level increased due to in case of malignancy, in case of inflammatory process, due to under the influence of inflammatory cells. That's why third criteria also concerning lactate dehydrogenase level, LDH level, pleural fluid LDH level more than 2/3, the upper limit of normal for serum HDL level. And additional light criteria, for example, serum albumin minus pleural fluid albumin more than 1.2 gram deciliter indicated transudative effusion. But for each lab criteria, we also should apply the criteria of evidence medicine. For lab criteria, it's very important sensitivity or specificity. in this slide you can see that 3 light criteria is sensitivity and 98% and specificity 83%. That's why it's higher level of evidence. By the way, in previous course you should know such criteria evaluation of pleural fluid, for example, optical density, serum protein level, pleural fluid protein level to serum protein level, pH, and real to reaction to inflammatory serum mucoid, present in case of transudate and absent, pardon, in case of transudate, real test, and present in case of exudate. But the way I would like to stress that light criteria more sensitivity and more specificity. But in this only one, this comparison with pleural fluid protein to serum protein protein, this only one criteria. Okay. And what about pH, power of hydrogen? Increase due to acid production by pleural fluid cells and bacteria. Decrease by hydrogen ion reflux from the pleural space due to pluritis, tumor, or pleural fibrosis. In this slide, you can see, for example, it's most of cases we can diminish of pH of a pleural exudate in case empyema, more significant malignancy and TB infection, and also due to under the impact of inflammatory malignancy cells, it's lead to diminish of glucose concentration. What's the main causative factor that lead to pleural effusion? First place is congestive heart failure. I would like to stress that it mostly lead to formation of transudate, no exudate. Congestive heart failure lead to formation of transudate. Pneumonia, second place. Pneumonia, second place. It's no transudate, yes exudate. Cancer, third place. It's no transudate, exudate. And pulmonary embolism, sometimes transudate, sometimes exudate. And viral disease, exudate, coronary artery bypass surgery, exudate, and cirrhosis, it's transudate. And other disease which is accompanied by diminish of oncotic pressure, including nephrotic syndrome, cirrhosis, and other. That's why the main causative factor of transudate is congestive heart failure. The third place for exudate, pneumonia, cancer. In the development country, tuberculosis. It's in this case transudate. By the way, I would like to stress that why left heart failure often lead to transudate. It's explained, but in the visceral pleura in normal condition in healthy person don't play an active role in the circulation of pleural fluid. Only parental pleura in the upper part secrete pleural fluid, and like a shower, this fluid passes during the lung, visceral pleury, diminish of friction of the lung, and drainage due to special pore. In case of left heart failure due to pulmonary edema, when alveoli filling there by congestive fluid, they open the special pore and visceral pleura start secrete of this transudate. The main aim to diminish of the pulmonary edema and for removing some volume of the transudate from the alveoli for surviving of the host. That's why, but if you will be asked what clinical signs of left heart failure, it's pulmonary edema. But why it's you should not ask about pleural effusion, because pleural effusion it's most common causative factor of pleural effusion is left heart failure. But in case of right heart failure, it may be also lead to formation of pleural effusion. But in main cause is left heart failure. And exudate bacterial pneumonia, carcinoma, infection, tuberculosis, connective tissue disease, and other. In this slide, you can see, for example, pleural effusion, and the causative CT scan help you to this foci. It's tuberculosis in the upper part of the lung. Here in the you can see this one. It's right side pleural effusion, and the causative factor, it's pulmonary embolism. It's normal vessels you can see without, and it's white color, and green color, it's the green color in the vessels, it's the thrombus, which block circulation. It's lead to formation of in fact, pneumonia. So exudate pleural effusion require further laboratory investigation, including cells count and differentiation for neutrophils in case of the prevalence of neutrophils in case of acute inflammatory process, lymphocytes indicated chronic infusion. More than 50% of lymphocytes occur in case of rheumatoid pleurisity, chronic fungal infection, chronic TB, sarcoidosis, hyalothorax, eosinophils, pneumothorax, hemothorax, in fact, parasites, mesothelial cells, more than 5% in case of TB pleurisity. And very important, the highest level of total protein level, more than 7 grams per liter in case of multiple myeloma. LDH level more than 1,000 in case of empyema, rheumatoid arthritis, rheumatoid pleurisity, malignancy. Amylase level in pH, also low pH in empyema, malignancy. We talked about cytological analysis. If you detect a bacteria, staining, gram staining help you to detect gram positive or gram negative, and other So I told the diminish of glucose level and its rheumatoid pluricity, empyema, malignancy. And pleural effusion, the mechanical responsible for pleural fluid low glucose include decreased transport of glucose from the blood to pleural fluid and increased utilization of glucose by the pleural fluid, such as by the cells of in pleural fluid, neutrophils, bacteria, and malignant cells. Pneumonic effusion start out as a sterile reactive effusion precipitated by pulmonary infection. Pneumonia plus pleural effusion, it's an indication for rapid diagnostic thoracentesis. But why it's necessary? Because light classification for complicated, uncomplicated, and indeterminate of parapneumonic effusion due to pH level, lactate dehydrogenase level. It's very important for determine our strategy of treatment. For example, if case of pneumonia and pH more than 7.2, lactate LDH less than 1,000, glucose more than 40 milligram per deciliter, it's uncomplicated. We should treat pneumonia by antibiotic. In case of virus pneumonia, we should treat using of antivirus drugs and observation. Complicated, it's pH less than 7.2, glucose less than 40, LDH more than 1,000, antibiotic and pleural drainage. And if case of indeterminate, it's very suspected to formation of empyema, antibiotics through serum thoracentesis, fibrinolytic, and drainage. Why fibrinolytic? You can see empyema as a chamber because formation of connective tissue septa. It's very difficult sometimes to remove the pus from pleural cavities because due to several multiple chamber formation. So sometimes it's necessary to surgical removing this several chamber of the with pus, with decortication of the lung. And by the way, you should know antibiotics are not indicated in case of low pleural pH because its activity significantly diminished in case of low pleural pH. That's why tube thoracotomy, fibrinolytics, thoracoscopy, and sometimes open thoracostomy and decortication. So it's very sometimes it's very difficult to treat this pleural process in the lung. And pleural effusion management, transudate effusion, treat underlying disease. Exudative pleural effusion management depends on etiology, and symptomatic pleural effusion, therapeutic thoracentesis, and malignant is you should direct patient to oncology department with this patient. Okay. Now, a few words about pneumonia. Pneumonia is acute infective inflammatory disease, preferably caused by bacteria. This affects respiratory part of the lung, which intra-alveolar exudation and parenchyma alveolar inflammation. And typical bacteria for community-acquired pneumonia, including pneumococcus, Haemophilus influenza, and typical bacteria, Legionella, Mycoplasma, and viruses, including, by the way, new coronavirus SARS-CoV-2, and very rare gram-negative bacteria in case of community-acquired pneumonia, which happen at outpatient condition. Other things in healthcare-associated or hospital-acquired pneumonia, ventilator-associated pneumonia. That's why Pseudomonas aeruginosa and this gram-negative microbes, which plays first place in case of such type of pneumonia, as for example, methicillin-resistant Staphylococcus aureus and other. In this slide, you can see the typically what's happened in case of bacterial pneumonia. To the left side, you can see the normal alveoli without inflammatory exudate, and due to bacterial infection, it's lead to filling this alveoli by inflammatory exudate. It's lead to disorder of gas exchange. Clinically, it's dyspnea and diminish of saturation in severe case. Oxygen unable to reach bloodstream. In case of virus pneumonia, it's also can lead to diffuse alveolar damage by now we have more evidence, more confirmation that virus pneumonia in case of SARS-CoV-2 infection lead to damage of endothelial. It's lead to damage of interstitial tissue of the lung. It's kind of interstitial pathy. We talked about interstitial disorders. What does it mean? At the last lecture, and endothelitis and the damage of endothelial lead to increase of permeability of the vessels. It's lead to activation of macrophages, which produce a lot of pro-inflammatory cytokines, hyper immune response to innate immune system, lead to formation of active macrophages, formation of a lot of pro-inflammatory cytokines. In final stage, lead to so-called of cytokine storms, which increase level of tumor necrosis factor alpha in EL interleukins 1, interleukin 6. It's underlying endothelial dysfunction and lead to microvascular and microvascular injury, accompanied by micro and macro thrombosis, vasoconstriction, and it's that's why virus lesion of the lung and SARS-CoV-2 infection, it's more deeper than bacterial affection of the lung. It's interstitial tissue, especially parenchymal interstitial, is also very important target for virus infection. By the way, in Russia Federation, we use temporary methodical recommendation for prophylactic, diagnostic, and treatment new coronavirus infection. In the world, it's National Institute of Health, for example, COVID-19 treatment, practically monthly updated this recommendation, and this diagnostic and treatment guidelines useful for each practitioner. So I would like to say about a few words about how can we detect severity of pneumonia, because if you met with severity, firstly we should use the specific scale. First is so-called group 65 or CRB 65 scales. C is confusion. It's abbreviated mental test score. In the case of, for example, disorientation person, in place of time, and other disorder for mental status of patient. In case of group, we also use blood, urine, nitrogen, more than 7 millimole per liter, respiratory rates more than 30 breaths per minute or more, and blood pressure. Diminish of systolic less than 90 millimeter mercury, and diastolic less than 60 millimeter mercury or less. Age, if patient 65. That's why if patient, for example, have got disorientation in person, place, or time, it's 1 point. Blood, urine, nitrogen, 1 point. Respiratory rate, more than 30 breaths per minute, 1 point. Blood pressure, drop of blood pressure, 1 point. And age, 65 and more, 1 point. That's why 4 points. 1, 2, 3, 4, 5. Pardon, 5. 5 point higher risk of mortality. If patient have no any 0, it's low risk of mortality. That's why it's dependent according to this group scale where patient should be treated. In the 0 home, it's by the way, for my advice, if patient have got 1 point and 2, also patient should be short hospitalization. Because, for example, if patient have a drop of blood pressure, it's infection shock, septic shock. Only 1 point. If patient have got respiratory more than 30, that's also a significant situation, and patient should be hospitalized. That's why it's, for my recommendation, short hospitalization. If patient have CRB or 3, medical ward. If patient 5, at ICU care, in intensive care unit directly. That's why there are a lot of other scales, for example, pneumonia severity scales, but it's very important because it's not sensitivity of this CURP or CRB 65 scales. We should obviously check patient pulse oximetry. It's obviously. If patient have respiratory failure, at least first stage, diminish of pulse saturation less than less than 94%, you should think about hospitalization patient. If a drop of pulse oximetry results less than 90, it's obviously hospitalization. But in clinically in hospital, in hospital, we also can check pneumonia severity index, and according to this index, you can check the stage of point, calculate, for example, patient more than 100 inpatient, mortality rates 30%. In the patient have less than 51 point, it's outpatient condition. It's more male, female, present of comorbidity, vital signs, mental confusion, respiratory, systolic temperature, tachycardia, blood urea, sodium, glucose level, hematocrit, pleural effusion, and other, and calculate and check the class severity. To optimizing of the community acquired outcomes, it's time to determine of pulse oximetry. If you suspect, you should evaluate practically simultaneously during first visit and first contact with patient with pneumonia. Availability to radiography, CT clock, time to take a sample of arterial blood. If patient have got a saturation less than 90%, you should obviously check the pressure of oxygen in the blood, in arterial blood. Taking blood sample for bacteriological examination before the first dosage of antibiotics. Time to first dose antibiotics less than 4 hours. Antimicrobial therapy in accordance with the existing guidelines. Using the available forecast assessment scales for all hospitalized patients with CAP, and estimation of the prevalence of vaccination in patients at risk. By the way, few words for differential diagnosis of virus or bacterial infection, but in the right part you can see the virus infection. It's mostly bilateral, mostly subpleural lesion. It's a ground glass opacity. In case of bacterial pneumonia, you can see mostly it's unilateral. It's right side of the lung, and consolidation and bronchography. It's lobar pneumonia, mostly in the case of, and this also you can see virus infection, ground glass opacity. In case of severe virus infection, it's also crazy powering, consolidation. And that's why for virus infection, the etiology therapy, including antivirus drugs now, we are living in pandemic of new coronavirus infection due to SARS-CoV-2 viruses. And we in our country, according to the temporary recommendation, we are now 12th edition recommended such antivirus drugs like favipiravir, remdesivir, human immunoglobulin, interferon alpha, and luminafenavir. In case of bacterial infection, in inpatient condition, we, in most cases, we should use and prescribe patient enzyme-dependent beta-lactams, amoxicillin plus clavulanic acid, amoxicillin plus sulbactam, ampicillin sulbactam, third generation cephalosporin, cefotaxime, ceftriaxone, respiratory fluoroquinolones, levofloxacin, moxifloxacin, ceftaroline, and carbapenem, eterpenem. Antibiotic therapy for virus pneumonia prescribed only if there are convincing signs of bacterial infection. It includes increase of procalcitonin level more than 0.5 nanogram per milliliter, appearance of purulent sputum, leukocytosis more than 12 giga per liter, in absence of previous use of corticosteroids, increase in the number of step neutrophils more than 10%. That's why this criteria for our suspicion of bacteria etiology in case of maybe simultaneously with virus infection. Pathogenetic therapy of virus infection, including, because we told that in case of virus pneumonia, it's lead to hyperactivity of innate immunity. We should use first line, it's systemic corticosteroids, dexamethasone, methylprednisolone, hydrocortisone, and local corticosteroids, budesonide. By the way, the very important thing, we should prescribe systemic corticosteroids only in case of diminish of pulse oximetry, less than 95. Other things, we should know ability to prescribe systemic corticosteroids. But other drugs also used for breaking innate immunity hyperactivation, hyperresponse, immune response. And Janus kinase inhibitor, tofacitinib, baricitinib, and for treatment of so-called cytokine storms, we talked about several pro-inflammatory cytokines which lead to these cytokine storms. For example, olakizumab, livilimab, tocilizumab, sarilumab. It's this monoclonal antibody which blocked interleukin-6, which play an active role for formation of these cytokine storms. Canakinumab, anakinra, block interleukins-1 beta. Also, it's very important pro-inflammatory cytokines. And necatimab, it's a monoclonal antibody which block interleukin-17, which also play an active role for activation of neutrophils. We told that cytokine storms and endothelial dysfunction and damage of endothelial lead to formation of thrombosis, microthrombosis. That's why it's obviously prescribed in case of affection of the lung. We prescribe anticoagulants. It's low molecular heparins, weight heparins, unfractionated heparins, and among low molecular weight heparins, it's enoxaparin, nandraparin, and other systemic anticoagulant, fondaparinux sodium, and oral anticoagulant, new oral anticoagulant, rivaroxaban, apixaban, dabigatran. So the time lecture is over. If you have got some question concerning this very important topic, you should write down in chat, and I try to answer for your question during other lecture. Thank you for your attention.